Routine indications for inferior vena cava filters includes contraindications to, complications of, or failure of anticoagulation in patients with prior venous thromboembolism. The ease of placement has broadened the indications to incorporate prophylactic placement as well. While protecting the pulmonary vasculature, placement of an IVC filter does not negate the already present predisposition of lower extremity thrombosis. Our case details a 55-year-old female who presented with acute on chronic lower back pain. The patient has a history of pulmonary embolism in 2011, which was treated with warfarin. A subsequent GI bleed resulted in the contraindication to anticoagulation and ensuing placement of an IVC filter. The patient was unfortunately lost to follow up, therefore, the filter was left in place until the time of her admission in 2019. The patient has a family history of DVT in 4 relatives and a stroke in her mother. The patient herself is not a smoker, and she denied the use of OCP or prolonged periods of immobilization. Physical exam showed bilateral non-pitting edema of the lower extremities to the thighs, which fluctuated throughout her admission. The patient also exhibited midline back tenderness, specifically in the lower lumbar region. On admission, the patient's creatinine was found to be 1.65, and this ended up driving the majority of her care throughout her hospital course, following a negative lumbosacral x-ray for her lower back pain. A non-contrast CT was performed to evaluate the kidneys, and a 3 mm ureteral calculus was appreciated. Patency of the IVC filter, however, was unable to be appreciated with this study. Due to a rise in creatinine despite medical management, a cystoscopy with ureteral stent placement was performed. In the following days, in spite of medical and surgical intervention, the creatinine continued to fluctuate unpredictably, seen in the laboratory results graph. Workup for nephrotic symptom at this time was also negative. Initially attributed to acute on chronic renal failure, the patient's lower extremity edema also failed to resolve. Therefore, cardiology performed an echocardiogram which revealed an ejection fraction of 75 to 80% with asymmetric hypertrophy. The following lower extremity ultrasound revealed a bilateral DVT shown in Figure 1. Hypercoagulable workup was positive for lupus anticoagulant. A CT with contrast, shown in Figures 2 and 3, was performed to assess IVC filter patency. The thrombus extended from the popliteal veins with continuous involvement to the femoral veins, iliac veins, and lower inferior vena cava. The thrombus also extended cephalad a short distance above the infrarenally placed IVC filter. Vascular surgery performed a mechanical thrombectomy with systemic heparin using angiojet and indigo penumbra. Clot triever device was performed using low doses of TPA. Figure 4 shows the patent IVC filter indicated with the green arrow status post thrombectomy. The patient's wavering creatinine was eventually attributed to thrombotic occlusion and gradually declined to normal levels after treatment. The patient was started on heparin with eventual bridge to warfarin and was discharged home. Common presentations of inferior vena cava filter obstruction include unilateral lower extremity edema, unilateral DVT, venous stasis, and development of collaterals. Our patient presented with the rare symptoms of bilateral lower extremity edema and renal dysfunction, which eventually improved after intervention. In this case, the patient received an IVC filter due to a contraindication to oral anticoagulation. This is a guideline widely accepted by most major societies. However, the increase in relative and prophylactic indications for filter placement has led to a shift in practice patterns. For example, the Society for Interventional Radiology and the American College of Radiology appropriateness criteria support the placement of an IVC filter in high-risk populations, such as patients with multi-trauma or patients with spinal cord injury. But the American College of Chest Physicians opposes this indication. A retrospective review disclosed certain factors to be associated with decreased filter retrieval. Patients with a limited life expectancy and those released to long-term care facilities showed statistical significance. Also, filters ordered by medical specialties as opposed to surgical specialties and patients lost to follow-up account for significant predictors for final filter retrieval. Having a systematic strategy significantly improves filter follow-up management. Multiple studies have shown that having dedicated personnel responsible for developing a database and arranging for follow-up appointments is effective in enhancing filter removal. Providers and patients need to both accept accountability and adhere to an agreed-upon plan of action.